Now start the PowerPoint. So she's a 76-year-old female, hypertensive diabetic. She had anterior wall STEMI in June 24th and underwent a primary angioplasty with PCI to LAD. That's on 24/6/2022. And 12 days afterwards, she presented with subacute stent thrombosis, again re-ST elevation. These happened in a center outside where they did a plain balloon angioplasty to the LAD on the same day, 6/7/2022. And later on, after 24 days of this procedure, on 1st of this month, August, she developed a subacute stent thrombosis with LV failure. And again, a POBA to left-handed descending with a thrombus aspiration was done on 1st of this month. And then she is surviving with a moderate LV systolic dysfunction. And she was referred to us for further management for optimization with the help of imaging. This is the angiograms of anterior wall STEMI in on 24/6/2022. You can see the left-handed descending with a tight lesion so close to the ostium and significant calcification down up to the middle AD. There's a lesion in the RCA also. They did an angioplasty with 2 stents, the middle AD at 2.75 into 26 drug-eluting stent with another stent of 3 into 26 millimeter drug-eluting stent with overlap. There was significant underexpansion of the area where there was a stent overlap. It was post-dilated with a 3 millimeter non-compliant balloon. And she's on dual antiplatelet. She has been on dual antiplatelet therapy, aspirin, ticagrelor 90 milligram twice a day, atorvastatin, bisoprolol, enalapril, and spironolactone. Next. So she presented with subacute stent thrombosis after 12 days of the primary angioplasty. You can see the stent thrombosed with significant lack of flow there. Next. Again, it was wired. LAD was the overlap area was dilated with a 3 into 8 millimeter non-compliant balloon. They could re-establish the flow in the LAD, but the underexpansion is still persisting. Down the stent also, there is some amount of lesion and maybe some amount of spasm also. And the patient presented again with a subacute stent thrombosis after 20 days of first subacute stent thrombosis. That is 1st August 2022. Next. Again, thrombus was aspirated. A balloon angioplasty to the LAD was done with a non-compliant balloon of 3 into 8 millimeters. Next. She was referred to our center for further management. This is the echocardiography, which shows the apical part of the anterior wall, the IVS and anterior walls thin with a LV function, LV systolic function of ejection fraction close to 35 to 40%. The RCA territory is contracting well. We did a coronary angiogram on 5th of this month, followed by imaging, IVS and OCT. And this is the coronary angiogram on 5th. Go to the IVS.
So you're just going to see the IVS pictures and OCT pictures going to be described by Dr. Mintz. The IVS and OCT.
Ashok, sorry, we can't hear you as well. Can we get his mic fixed up a little bit, please?
You can't hear me? Did you hear the presentation well?
Yeah, we heard the presentation. You're much better now.
Okay, so the OCT and IVS was done at the time of the angiogram done 5 days ago. And Dr. Gary Mintz is going through that. 3-4 features that I want to emphasize when we go to that is, firstly, the lady is being compliant with her antiplatelet regimen. The second aspect is that there is no prothrombotic state. So all we're looking at is the stent itself, and is that the cause of repeated thrombosis? As you can see, that it's happening at the same point of the stent overlap, and therefore that is our area of interest. And certainly there's a residual stenosis in the proximal part, which is the index lesion from which the primary occurred. And Gary, over to you to define what we see on imaging for this stent and the vessel.
Thanks, Ashok. Can you hear me?
Can you hear Dr. Gary Mintz? Good.
Okay, fine. So we're going to start distal with the IVUS. You can see that the LAD at this point is pretty much normal looking, and there's a muscle bridge right here. Okay, just wanted to give you that as a point of orientation. So we're going to start pulling back, and we'll come to the distal edge of the stent. You'll see a little early neointima of this echolucid neointima. At this point, the stent is pretty well expanded compared to the distal reference. But then we get into areas where the stent is not only elliptical, but also underexpanded. And we'll be coming up to that kind of soon. So maybe I'll grab this and hasten it along a little bit. And so now we get to an area where the minimal stent area is more like 4 square millimeters. A couple of skip areas where it's about 4 square millimeters there and here. And you can see the amount of calcium. This is totally socked in with circumferential calcium. This is probably the point of overlap, part of the point of overlap of the two stents. At this point, the stent actually plumps up to about almost 8 square millimeters. And then we're going to get to an area more proximal, which I will again hasten. So this is probably the original lesion. And it's likely that this represented a calcified nodule as the cause of her STEMI back in June. The other point that's important is we get to the proximal edge, we see a few malapose struts, which is okay, but then the LAD ostium, which is unstented, is about 8.5 or more square millimeters. So we've got 8.5 square millimeters here in the proximal LAD. It rapidly drops down to about 5 square millimeters. We've got some mid-portion area of 4 square millimeters, and then the distal vessel looks normal. And lastly, we've got, to show you the left main. The left main is calcified, but non-stenotic. Okay, right there. Okay, now I'll switch to the OCT because this is the order in which these were done. Can you see the OCT now?
Yes, we can.
Okay, so we're going to go play back from distal to proximal. Whoops. You can see again this early neointima here. And then we get to an area where the minimal stent area, just like on IVUS, is about, not yet, a couple of skip areas, about 4 square millimeters in this general area, here and here. And that's at the site of overlap. You can see the overlap stents very nicely in the cartoon below. And then the stent plumps up without any neointima. And then we'll take a look right at the index lesion from last June, which is here. And at this point, this stent area is about 5 square millimeters. And this probably represented, again, a calcified nodule as the underlying mechanism of her STEMI. And then we get to the proximal edge, and you can see that the stent itself starts in the LAD and does not cover up any part of the circumflex. So we've got some areas of modest stent under expansion over some length at the site of stent overlap. And again, the other thing I want to show you on the OCT is how socked in this calcium is. This is circumferential calcium that is, at times more than 1 millimeter thick.
All right, perfect. So Gary, thank you so much for showing us the IVUS and the OCT and kind of highlighting some of the challenges that we're probably going to have with this case. Just to recapitulate the clinical history, this is a patient that had ACS, had 2 recurrent stent thromboses, one of which, the most recent one, the patient just underwent POBA and now is on the table, and there looks like there's at least one area of stent under expansion where there's overlap of the prior stents, and then potentially some under expansion at the site of the original calcific nodule. Before you
Correct.
tell us, Ashok and Jabir, what you're going to do, why don't I turn to the panel and ask, how would you go about tackling this, and are there going to be certain considerations that Ashok and his team need to worry about?
It's a near 360-degree calcium, superficial calcium, and an underexpanded stent. I think we should start with IVL here. IVL has to be done.
So clearly we're going to have to do something about the calcification behind the stent in order to expand it. So I think IVL is one of the things that I think are probably going to be considered. We already saw the IVL balloon on the table as well as the generator. So I suspect they're going to be using that. But aside from IVL, are there other potential strategies to consider? And would someone use something else besides IVL?
An OPN balloon.
Okay, so I think an OPN balloon is a potential strategy as well. Anything else?
Before that, I think we should look for any coagulation problems with the patient, like protein C or protein S deficiency, because she had multiple stent thrombosis.
Agreed. I mean, I think there potentially could be a hypercoagulable state, but it seems like, at least mechanistically, we see that there's an underexpanded stent that hasn't expanded. So, I think if it looks like a duck and quacks like a duck, it probably is a duck. So I think it's probably related to the mechanical aspects, but I don't think that that's unreasonable. And the other question I have is the potential use of laser in a case like this. Anyone else on the panel? So why don't we do this with everyone here in the audience? Why don't we raise our hands? Who says IVL should potentially be used as our first strategy here? Okay, that's
50%?
Yeah, I'd say more than 50 for sure. And then who thinks that an OPN balloon should potentially be used here? Okay, a lot less, but definitely a few hands. And then who thinks that potentially laser atherectomy should be used? Okay, so the least for that. And so right now, I think the consensus here is potential use of IVL.
I think IVL followed by OPN is the best strategy here.
Right, so that was the other thing I was going to say. So it doesn't have to be one strategy only, it can be synergistic. And so a combination of strategies may be appropriate. So Ashok and Jabir, again, it's only one layer of stent with one area where there's overlap, correct? It's not more than one stent? It's not two layers or anything like that?
No, the overlap is the 2 layers of stent. And that's where, should we say, the underexpansion is. And that's where recurrent thrombosis is. I had stated right up front that there's no hypercoagulable state. That's very reasonable thought. Drug compliance is another reasonable thought. Was she compliant? All that has been looked into, and we're really faced with what is right in front of us, which is an underexpanded stent. Normally, Gary, we would have thought that such underexpansion, which is not severe, would have been more towards a restenosis rather than recurrent acute thrombosis.
Correct.
Is that correct? Is it
correct?
For thrombosis, you see far more under expansion, but all said and done, twice it's occurred at that point, we need to treat that.
Well, yeah, I mean, I think we can't leave that behind.
Correct.
Because she's told us what she's going to do.
So clearly optimization is important. My next question to Gary, okay, our strategy is going to be clear. We have circumferential calcification outside 2 layers of stent. We have thick calcium. We know the tool to use is shockwave. That's very clear, IVL. And I'm absolutely clear in my mind that after IVL, we would need to go to the best form of non-compliant balloon. And for me, the best form of non-compliant balloon is the OPN because it gives me pressures without expansion. And that is what I need. Remember, IVL only softens or may crack some of the calcium, but it will be the balloon to get me the maximum expansion or maximum pressures to expand. So my question to Gary would be that when I do that, I need to be sure of the vessel size accurately because I may end up going to ultra high pressures. So my issue around vessel sizing is not just to know the sizing, but for the safety of ultra high pressures. So Gary, what do you think the vessel size is?
Well, it's in the 2.5 to 3 range.
Right.
And it's an LED, so it tapers. So it's more 2.5 distally and 3 proximally.
So 2.5 distally, 3 proximally. We saw that it was 3.15, 3.2 at that point.
Right at the ostia.
Right at the ostia. So, and by the way, 3 non-compliant balloons have been tried there. Our approach would be a 3 IVL, deliver our 80 pulses, and I'll show you how we deliver the 80 pulses. When you get back, where do I place the emitters? Would it be right at the center? Would it be eccentrically positioned? The emitters would be firing at the calcium. That is very important. And let's see what happens after 80 pulses. And then we'll come back to you. I think you got a lecture,
All right,
but that's
perfect.
good as strategy. By the way,
Okay,
in the strategy is two other important things. And this is again for the young career interventionists. I'm very clear. It's a 7 French guide. It's through the femorals because now we have devices. We have ultra high pressure balloons. We may need other tools. And therefore, good guide support is a must. A good wire support is a must. So at the moment, I have a Grand Slam wire down the vessel. It helps me to go to ultra high pressures on this wire. It helps me to deliver devices. And it also helps me to deliver any bailout devices in cases of the situations of perforations, etc., and so on and so forth. So Grand Slam, which is a non-coated wire, will take ultra high pressure balloons easily without the coating sticking to it. It's got no coating on it. And that's where we are at the moment. So I'm thinking 3 steps ahead in terms of support and in terms of delivery of any devices and in terms of any complications that we may face. So here we are.
Yeah, I think that's fantastic. I mean, I think that, sometimes delivery, particularly in a underexpanded segment of the IVL balloon, can be fairly challenging, even with the OPN balloon. So the fact
are you going off to the top at the moment? Are you going to stay with us?
No, we're going to stay with you for a little bit. The reason for that is Dr. Ali still has to upload some of his.
So there's another thing that I'd like to tell you is that had this been an instant restenosis, coming 3 months later, 6 months later, it would have still required an IVL, but I would have treated that by a cutting balloon first, because otherwise the tissue inside the stent would not have allowed the IVL pulses to easily move outside the stent to the calcium which is surrounding. And that's because the tissue would have absorbed it. And for me, the first step would then have to be remove the tissue and then get an IVL. Otherwise, IVL would be less effective. But at this stage now, this is early stent. There is no tissue inside the stent. And therefore, it's just easy for us because now the IVL balloon would be directly on the metal, should we say, and there's no tissue or a pillow in between. So
sorry,
here we are.
But what size IVL balloon are you going with? Are you going with a 2.5 or a 3?
3.
Oh,
this is a 3.
3. Okay.
So while this first pulse is going to be at the center and deliver 2-3 pulses right at the center, you will actually
Ashok, can you show us the angiogram? Ashok, can you just ask them to switch to the angiogram, please?
You can see the angiogram now?
Yeah, now we can. Perfect.
And you can see that overlap segment. At the moment, I have the 2 markers of the balloon on either side of the underexpanded stent, the double layers. But after a couple of pulses in this, I would move my emitters to that side to deliver the maximum impulse, should we say. So here we are. Can we switch the IVL on?
Switch
that button on? Yeah. Okay.
Yeah, right.
So here we are delivering the IVL, and I'll do it on the fluoro, or I can even do it for you. So go to 4 atmospheres. Who's handling that? So you're going to 4 atmospheres. You want to be sure that there's.
So I'm at 4, sir.
Okay, and here the IVL pulse is getting delivered. Now, we must, after this, are we concentrating on this lesion because that's our lesion of action should be.
Shall I go to 6 and come? Right.
And deflate. And you just give.
So Ashok, sorry, quick question for you. So why put the balloon in the middle of the lesion? Why not just have the emitters right at the site from the get-go?
I'm just going to do that. I'm going to put the emitter on the side, the first emitter, and you can see that emitter, which is around, the emitters are 2, 4, 6. So there we are. Okay, here's the emitter coming in, and let's see. Negative, good enough negative?
Yes, negatives.
Yeah. Okay, so that's more like the emitter on the lesion. Okay, go up.
I'm at 4.
Yeah. So I hope you understood that point about the emitter. While the two emitters, the maximum impulse and is given at the emitter, and that's where the maximum impulse comes out, 6 and negative. So let's see how much this progresses over a period of time. You see the enhanced image. You can see can you see the enhanced image? There's a nice indentation coming on the balloon.
Yeah, we can see it, Ashok.
So let's just show you what we've done. We fired our 80 pulses, 8 cycles at the lesion. Let me just show you a couple of pictures. We've done it eccentrically, as I said. The emitters are at 2 millimeters and then 6 millimeters. The distance between the two emitters is 6 millimeters, and then there's a final 4 millimeters to the distal marker. So the emitter, the proximal emitter is eccentrically placed. They're not central, they're not equidistant. And therefore we've done let's show you a couple of images, the previous runs. So we've moved the balloon backwards, forwards, and we can go minus. You can see that that's eccentrically placed. That's more at the distal emitter. This is more at the proximal emitter. But we actually had the emitters always at the point of the maximum overlap and the maximum under expansion. Did we make a difference? Did we see an expansion of this balloon completely? No, we did not. We felt that we could again check it up with IVUS, and so Gary has looked at the IVUS. Gary, any comments on a repeat IVUS after the 80 cycles?
Sure, a couple things. The MSAs have essentially not changed, but there are a couple of areas where there appear to be cracks in the calcium. Like there's one here. And if we look, we can see not only reverberations, but some suggestion of penetrating some of the calcium with ultrasound. So this is an inferential that we have created some cracks. The proof, of course, will be what the OPN balloon does.
Do you see those reverberations, or were those there before, Gary?
Not as prominent, which is interesting.
Right.
They're much more prominent now.
So of course, the proof of the pudding is going to be what it does with the OPN. And so we now have a 3 millimeter OPN. Now you can see our images. And we have a 3 millimeter OPN there. And we're ready to go up on the OPN. The way I go up on the OPN is clear that one can go up to 20 atmospheres fairly rapidly. And then from there on, I take it up gradually, watching the expansion of the stem, keeping at going up every 2-3 atmospheres, keeping it there for 10 seconds, moving up till I get to 35 atmospheres. But I'll be giving 10 seconds between each. If we need to deflate for any ischemia, etc., and this is probably not going to happen in this case, we can always deflate and then go up. But be patient with the OPN, and you don't need to just take it straight up to 35 and 40, because let the lesion have the pressure and gradually expand. And often at times, as you've seen with the non-compliant balloons, if you keep it up for 20 seconds, you suddenly see the lesion giving way. At this stage, you always want to be sure that you've got all your accessories around you for any bailout devices that may be needed, which we don't think we would, because I think we're appropriately sized to the vessel. And all we're doing is exerting pressure rather than doing anything more. We're not over-expanding that lesion. So here I was taking it up. There we are, right? Centering it at appropriate place, and let's go up. Okay.
I'm at 10, 15, 20.
Yeah, okay.
25.
Now just stay at 25, and then we'll start going up. 27.
So just a comment for the audience. Ashok, we talked about this before.
Correct.
IVL will crack the plate, but your NC or OPN balloon is going to break
29.
the plate.
29.
So we are at 29. 32.
32.
34.
34.
35.
35.
And I'm going to sit at 35. I would go up to 40, but I would sit at 35 first, and then deflate after a bit, analyze it with IVUS. Let's see what lumens that we've achieved, and then take it up thereafter. So
Ashok, you have, I was going to ask you, you have the device detection in the room. How does the balloon look on the Philips device? I know we can't see it. That's a great indicator if the wire is staying central, whether or not you're getting additional expansion.
We're certainly expanding. We still got a residual stenosis, but we're expanding. And now I'm going to deflate. Okay, deflate. So we kept it up for close to a minute. And as soon as we deflate, we want to puff. So can we have an injection? Okay.
Yeah.
So if everything flowing, looking good, I think I can go up on the pressures. That's going to be good. So Gary, I'm not going to check it up with an IVUS. I think we can go up on the pressures.
But,
no, not yet.
But if I can make one,
there's
two things that are happening. One is obviously you're going to high pressures, but you're also leaving it up for a longer period of time.
Right.
And with conventional non-compliant balloons and traditional high pressure, what we see all the time is people inflate the balloon and immediately deflate it rather than letting it sit, because it does take some time for the pressure to be transmitted.
Correct.
And there actually are some studies that have correlated the duration of high pressure inflation with ultimate stent expansion.
Right. Yes. Yes. Gary's right. And that just doesn't go for this lesion. It goes for every stent implantation. Prolonged inflation gets you larger lumen with a stent. Repeat inflations gets you larger lumen.
Correct. You know, the trend is to deflate before you've even fully inflated.
Right. So let's go up again. Let's go up to 20.
So I'm at 20,
22,
22,
24,
24,
26,
26,
28,
28,
30.
30.
So,
Okay.
guys, I have an interesting
32,
theory here.
32,
I'd like to hear your opinion on.
34,
34,
You know,
36,
what kind
36,
of stents were these? And what were
38,
the diameters of the
38.
stents?
and we're now at 40. Well, let's go to 40.
Yeah, 40.
So we're going to just set at 40 now.
So while we're up there, Ashok, Zi just asked a question. What were the original stent types, and
Onyx.
what were the diameters of those stents?
Did it come down?
Yeah, it came down.
So I think it came down. It came down. That means that it could have ruptured.
Ruptured.
As well. So that's okay. Yeah, so it was Onyx 2.75, and I think it's a 3 negative.
So, you know, I think what your mechanism of inability to expand here is actually the overlap of the 2.5 and the 3.0 stent, because the 2.5 Medtronic will only go to 3.5. And so
2.75. The distal was 2.75. The proximal was a 3.
Yeah, so the 2.5 Medtronic, I think what the maximum it goes to is
Negative.
3.0.
The 3.0 goes to 4.
3.0 goes to 4, but the 2.5 goes to 3, right?
No, the 2.75 would go to a 3.75. Onyx.
Because it looks just, if you look at where it's right where the overlap is. And I always think of these like a belt buckle, right? And it's metal, so no matter how much you do, inflate, it just recoils right after.
Negative. So just hold
Negative.
this guiding.
Negative.
Is it good? Hold the guiding.
Yeah.
So
It's so tough.
yeah. So the opium is, as it ruptured, of course, becomes a very large profile, and it also, in a way, sticks to the wire. So just getting that out.
Yeah, I mean, the other thing is with the opium, when you go up to 40, it really clamps down on the wire. I mean, you have a grand slam there, but if you have Xi'an blue, then yeah, so one of these strategies is always to just have a second wire ready, because frequently it'll just seize on the wire as you pull the.
That's right.
So maybe for the audience, we can say what the mechanism of that is when you go very high pressure, 2630. So there's one small segment of some wires where the 009 inner core is inside an 014 balloon. So when you inflate it 30 atmospheres, it's like taking a wrench and pinching it. And so that's why the balloon gets stuck on this very, very small segment. Xi'an blue is absolutely notorious for that.
I like the All-Stars, by the way. I've never had them stuck to the All-Star because it's just sheer metal without any coating. And
Yes,
that's
sir.
what I use. So let's just have a look at what we have at the moment. So we're better, and this is the time to look at it with IVUS, certainly.
So shall we change
Yes,
the
we're
wire?
going to change the wire. So we're going to come
Another
out with this
grand
wire.
slam or run through?
Yeah, well, we could actually take our run through.
There is also an OCT catheter here. Any particular reason to use IVUS and not OCT?
Oh, good, good. Thank you, thank you. So we're now going to do an IVUS and make you see those pictures, but it does look visually better. So can I have the needle to shape this wire? This needle there? Yeah. So
Angiographically already looks a lot better, Ashok.
yeah, that's what I thought. So let's see, the lumens that we have.
Angiographically
This is, it just goes with our discussion this morning. Remember our discussions around when you use IVL for underexpanded stents. I use ultra high pressure dilatation fairly regularly, even believing that it's the best non-compliant balloon I have. So even if I don't need to go up to 35 and 40 atmospheres, even for going up to 20, even from 20 to 30, I feel that that it's probably the best non-compliant, more predictable non-compliant balloon that you have. Let's go to LA40, please.
Yeah, so while you're doing that, quick question. So Ziad, there's only one layer of stent here. I mean, what's the likelihood that the shock waves are actually going to be able to break calcium behind one layer of stent? So
actually
last month,
no, it's two layers of stent, because there's overlap.
That's where the overlap is. Yeah, yeah. So, but with one layer, what's the likelihood? And then with two layers, what's the likelihood?
I mean, the honest answer is I don't know. What we know is that shockwave can be effective at fracture of calcification, even with the presence of a freshly deployed stent. The amount of damage that's caused to the polymer in a Abbott stent is 6%, Medtronic is 7%. You get no damage in a Boston Scientific stent because there's no polymer on the luminal surface. So I guess on balance, if you have an underexpanded stent and you have to damage 6% of the polymer, it's probably worth it. So obviously lesion prep before is better, but if you have a bailout, then IVL should be safe and effective.
So last month, there was actually a publication, probably the largest case series that they have specifically on one layer of stent and the use of IVL. And they looked at 50 patients. This came out of France, and they found that there was a 90% success rate if there was one layer. Yeah. They didn't comment on two layers. At least anecdotally, I find that it works half the time, and it doesn't work half the time, particularly when we look at our brachytherapy patients.
Can I comment on that? The
yes, please.
The Crunch registry, and that's the 70-patient registry looking at underexpanded stents.
Shall we go for the pullback?
22% of those patients. That's right. Yeah, 22% of those patients, by the way, had 2 layers of stents. And by the way, that was surprisingly in that registry, which is obviously multi-center, it was co-lab but not protocol. It actually it was not the only 2 variables associated with failure was not 2 layers of stents, which was interesting. And I would have thought 2 layers of stents would not allow us to get to the calcium outside. Okay, now we're seeing that this is where we are. Gary, your comments.
So it's, I'll obviously stop and measure. It looks a little better. It doesn't look a lot better.
So this is the time to look at the MSAs, isn't it?
Correct. This is, my eyes are not that good. So I always stop to measure.
Yeah.
Because I can be wrong. And 1 square millimeter means a lot.
Yeah, absolutely. And,
so Gary,
angiographically, by the way, angiographically, it doesn't look, it looks better.
It looks better.
Gary, is this a stent effect or a calcium effect?
What do you mean?
Or both.
Do you think, I mean, this has happened at the overlap of the 2 stents. The small stent is on the inside, the big stent is on the outside. So is the small stent inhibiting the expansion even with the larger
Oh.
balloon? Or is it calcium?
Possible,
Move it forward.
or a combination. I mean, the calcium thickness here, Ziad, is impressive. I mean, angiographically, it looked like there was a stent before they even stented it. So we probably bought a square millimeter.
Okay, so Larry, now I'm going to be at the lesion itself so that you're not having a pullback and you're really looking at the lesion. It's manual. Okay, let's go manual.
Oh, manual.
Yeah, no pullback.
Should we start again?
Yes.
The meeting is on. Recording is on.
So this is it. You add the double layer.
Right,
This is the best.
There was
we
a
have.
right, and that's 5.2.
5.2. Okay. So you got 5.2.
So we bought about a square millimeter.
Yeah, I'm going to go back with an OPN again. I don't think I'm going to upsize that OPN. That OPN ruptured. I'm just going to lay it there again for 40 and see what we can do. But certainly not go to a 3.5 OPN, but do a more prolonged inflation with an OPN.
I mean, Ziad, some of the calcium thickness, sorry, some of the calcium thickness was easily over 1 millimeter.
Yeah,
Easily.
so that's where Darshan and I were just talking about what the utility of laser would be here.
Yeah, what would it be? Would we be able to? So it's clearly beyond the realms of any.
Sorry, a new OPN 3.
Yeah, that's right.
New
It's
OPN
clearly
3.
beyond the realms of any
310.
stent ablation by rotational atracty. The lumen is too large.
315.
Now. How would laser be?
We have a 315. Is it okay?
Yeah, 315 is fine. So how would laser be at this stage? It's wide open, yes. Giving contrast at that time and seeing how it would. We are at 5.2 in your lab. Now we don't have laser here. I have laser with me in Delhi. But would you be stopping at this point after the next OPN? Because I think this is probably the best we're going to achieve in that area.
For me, this is a antiplatelet and anticoagulant for 3 months because I don't know the mechanism of stent thrombosis. I stop the anticoagulant at 3 months when this is endothelialized. That's my strategy. This is a pharmacotherapy case now.
And certainly one of the things, of course, I'm going to do is use the OPN on the proximal lesion as well. We must remember that we've got to optimize that as well. And then finally, we would end up with a drug-eluting balloon, I think, because I think the stent has been messed around quite a lot, and we don't know what its drug elution characteristics are, as it has been intervened at least 3 times in the last 1 month. So we got to take care of it.
I think that makes a lot of sense. Did you use any of the IVL previously on the most proximal lesion, Ashok?
No,
or was it all?
No, I wanted to deliver every bit of it and this on this point because I think we're going to use the OPN balloon on the proximal part. Okay, so here we go up again. Go up. While you're at it,
it's 10, 15, 20, 25, 30.
Yeah, just sit at 30. And we're going to go up gradually now.
32.
34, 35.
34, 35. 35. Holding at 35.
Z, I wanted to ask you,
yes,
why are we saying, is 80 pulses good enough? Maybe 160 pulses could be better. Do we have any understanding around this aspect? For such
80 pulses was totally arbitrary. We just made
arbitrary, isn't it? That's right.
Totally arbitrary. And
so
then once you do the FDA testing with 80, that's your number. That's how many you get.
34.
So now there is a new balloon that's going to be coming out with an increased number of pulses.
36.
That's already available in the peripheral. It's going to the coronary. There
40.
may even be another emitter. So you'll have longer segments you can treat and you'll have more pulses. So it's in the works.
All right, Ashok, we're at the end of our time, unfortunately. So maybe we'll just have one more inflation at the proximal lesion just to make sure that gives as well.
That's right. And this is 40 and this is not bad. I mean, Darshan, you can see this is at 40 and this is not bad.
Yeah, I agree, for
I mean,
sure.
your balloon looks fantastic. I mean, this is a good result in this type of lesion with a minimal luminary.
That's right. So I'm keeping it up for a minute and a half. And I think that's the max we'll get out of it. Okay, and it's not bad at all.
Perfect.
To
All
where we
right,
started.
Ashok, Jabir, Gary, thank you so much. Incredibly instructive. I mean, the fact that you were able to do anything with this lesion is impressive in and of itself. So thank you so much.
Thank you.
Fantastic.
Right, Gary is looking visually. Look at that.
I saw.
Shall I come down, sir?
On the screen over.
All right.